heart could be full of blood at least half the time, and then you could ever have a heart attack because of poor blood flow to the heart. And that's because I really missed this one really important thing, and that is that the blood that is going through the chambers of the heart is not connected to the capillaries of the heart. So although it's counterintuitive, what you have to do to get blood to the capillaries of the heart is you have to pump it out of the chambers into the arteries of the heart, because arteries lead to capillary beds. Yes? Okay, so question for you. The heart needs systemic or pulmonary blood flow? Yeah, it needs systemic blood flow, right? It needs high oxygen blood, okay? So this is what I misunderstood, and I'll bet a lot of you guys do too. A lot of people think that heart attacks happen inside the heart. They definitely don't. Heart attacks happen because the blood flow that is going to the capillary beds of the heart, and the heart is a blood hog. It's only about 1/200th of your body weight, but it gobbles up about 1/20th of the oxygen. Okay, it's really, really it's really oxygen expensive. So how you get blood to the heart is the blood has to leave, and it has to go into your big systemic artery, which is what? The aorta. Okay, and then it gets dibs first on that systemic blood. First dibs is the first 2 branches off of the aorta, and the only real big branches off of the ascending aorta are the left coronary artery and the right coronary artery. Okay, so what's going to happen is those coronary arteries are going to branch, and ultimately what they're going to do is lead deep into the heart muscle wall itself, yes, and deliver blood to the capillaries in the heart muscle wall, but they're going to go from the outside in. So all that blood that's going through the chambers doesn't do a damn thing for the heart itself. Okay, you with me? Okay, so I want you guys to think about this and as you look at it. So what we have is we have this one, which is the left coronary artery. You can't see very much of it because look, it tucks back behind the pulmonary trunk and under the left auricle. So the only place that you're really going to see it on an intact heart is just poking out right there under the left auricle. This is the left coronary artery, and the left coronary artery is going to give rise to 2 arteries that you need to know. It gives rise to more than that, but most of them are so variable between people that we don't make you memorize them. We make you memorize the ones that are pretty consistent between people. So this left coronary artery is going to give rise to most of the blood flow to the left ventricle. So the left coronary artery is going to give rise to this vessel right here that runs down the anterior interventricular sulcus. It's going to be called the anterior interventricular artery. Okay, it's really, really freaking important because it gives most of the blood supply to the left ventricle. And the left ventricle is, of course, pumping to all of systemic circulation. It's so important that when it gets blocked, they call it the widowmaker. Yeah? Because if it gets blocked, then what's going to happen is your left ventricle is going to fail, and then you're dead, generally speaking. Okay? All right, so this is the anterior interventricular artery. And then if you follow the other portion of the left coronary artery, it wraps around in the coronary sulcus as what we call the circumflex artery. And the circumflex artery sort of wraps around the back. And circumflex means like it's bending. Okay, circumflex artery, good. Okay, and that gives rise to the blood flow to the backside of the left ventricle. Okay, so now let's talk about this one. This one right here comes out and runs under the right auricle. This is called the right coronary artery, and the right coronary artery runs all the way around in the coronary sulcus. So this is right coronary artery, yes? This is still right coronary artery, still right coronary artery, all the way back to here, okay? And it gives rise to 2 arteries that you have to know. And those 2 seem relatively arbitrary, but they're the ones that are pretty consistent between people. And that's this one right back here. This one right back here is the posterior interventricular artery that runs in the posterior interventricular sulcus. That's where it runs, okay? And which direction is blood going to be going through this one? Down, yeah, over and down, yeah? Okay. And then this one right here, okay, that's close to the margin of the heart. This is called the marginal artery, or sometimes the right marginal artery. Sometimes they leave off the word right because there isn't a left one, okay? Okay, so What's this one, guys? Left coronary artery. You can only label it that to here. What's this one? Anterior interventricular artery. This one? Circumflex. What's this one? Right coronary artery. What's this one? That's the marginal artery. And this one? Posterior interventricular artery. Okay, so what those arteries are going to do is to split into little arterioles and then ultimately into microscopic capillary beds to give rise to all of these capillaries, yes, that are in the heart, okay? And then, of course, what's going to happen as you get into the capillaries of any systemic capillary bed is that you're going to drop off oxygen, pick up carbon dioxide, drop off nutrients, pick up waste, right? Of course, the blood that's going to be coming back from the heart ultimately needs to be dumped into which chamber? Yeah, into the right atrium, right? So we're going to gather it all up. We're going to dump it into the right atrium through a few vessels, one of which you already know, the rest of which you may have learned in lab, I don't know. Okay, so now this guy right here that runs in the anterior interventricular sulcus is called the great cardiac vein. Which direction is blood going to go through that? Up, yes, right? It's going to go up and it's going to dump into the coronary sinus. The coronary sinus runs in the coronary sulcus. Yes? Okay. And then it's going to dump into the right atrium. But we have to pick up blood from a few other places. So if you don't want to memorize these, just go anterior, wrap around the back way to all the way back to the front. So go counterclockwise, because this is the great cardiac vein. This is the middle cardiac vein. Yes? And the middle cardiac vein runs with which vessel? Which artery? Posterior interventricular artery, and it dumps into the coronary sinus, right? And then this guy right over here is the small cardiac vein. And the small cardiac vein dumps into the coronary sinus, right? And it runs near which vessel? Marginal. So if you don't want to remember where the great is in the medium and the small, just start on the front and go counterclockwise until you get back. So great cardiac vein, middle, small. Yes? That make sense? Okay. Otherwise, you're going to have trouble remembering which one's which. Okay, so let's just make sure that you can do that like on an intact heart. Okay, what's this pair of vessels? Artery first. Anterior interventricular artery. By the way, clinically, a lot of times they call this the LAD, the left anterior descending artery. So this is the anterior interventricular artery. What's this vein? Great cardiac vein. Good. Okay, what is this vessel right here? Left coronary artery. That's the only place that you can see it. And this vessel right here that's wrapping around? Circumflex. Good. Okay. How about this artery? Right coronary artery. What's the vein that's hard to see in there? It's actually coronary sinus all the way around there. That's the coronary sinus. Okay. What is this artery? That's the marginal artery, and this vein? That's the small cardiac. Okay, coronary arteries, cardiac veins. Coronary arteries, cardiac veins. Okay, let's do the back ones. Back ones. Okay. You don't actually have to do this one. What's this vein first? Middle cardiac vein dumps into the coronary sinus. What's this vein? Artery. Posterior interventricular artery. Yeah? That makes sense? Okay. So let's go back to heart attacks. So how the heck a heart attack occurs is that these arteries are small to begin with. Yes? They're relatively small to begin with. And then if you have the typical American lifestyle of eating In-N-Out Burger, or let's be serious, McDonald's and Taco Bell, multiple times per week with very, very little exercise, what happens is you start to build up cholesterol deposits on the insides of your blood vessels. And as those cholesterol deposits build up on the insides of your blood vessels, what they end up doing is compromising blood flow to capillary beds in the heart, and you get a blockage. Yes? And when that blockage occurs, anything downstream from the blockage will be cut off from oxygen, and then the tissue will die, right? But it happens on the outside of the heart, not within the heart, right? Does that make sense? Okay, so a couple of things that they can do after that occurs. This is called an angioplasty, and with an angioplasty, what they do is they shove a balloon into your vessels. Once it gets to the right area where there is a blockage, they inflate the balloon and it opens up the blockage. Sometimes they'll put a stent in, and the stent is like a rigid tube that holds it open, okay, to allow flow to go through again. And then if this isn't a possibility, or if you've already had one or two or three, then what they can do is they can do a bypass. You guys know what a bypass is? Most people don't know what a bypass is. So you've probably heard of like up to quadruple, single, double, quadruple bypass surgery. When someone has clogged up arteries in their heart and their heart is not getting adequate blood flow, it could be occurring at one place or two places or three places or four places, right? And if angioplasty is not something that they think is going to work or last for very long, they can choose to do a bypass. And when they bypass it, it is basically like providing a detour with traffic, okay? So what happens is they take a vessel from somewhere else in your body, okay? Historically speaking, the most common place was the great saphenous vein, but we'll see today and tomorrow and Wednesday why using a vein to replace an artery is not plan A. I think I told you guys before that if you are male and they need to do it, a lot of times they'll use your mammary artery, okay? So what they are going to do is they're going to take that artery and they're going to, let's say the blockage is right here, yeah? They're going to attach the artery directly to your aorta and sew it in. And you're going to bypass the blockage, yes? And attach it directly to this artery, right? And then sew it in, right? That's what a bypass is, okay? And we have on Redwood campus a cadaver with 2 bypasses, and I think we've got one with 1 or 2 here as well. So you can see those. Now, why does this stuff happen so often? Well, Americans are typically not very active and we eat way too many animal products. And so this is the typical American predisposition, and it is almost always preventable. Almost always preventable. So this has primarily to do with diet and exercise. Now, you can definitely have a genetic predisposition to cardiovascular disease, but if you were a someone who is genetically predisposed to atherosclerosis, but you were a marathon runner and a vegan, you wouldn't get it. So it's related to those two things. So anybody have any questions? Heart attacks? Anything? No? Did you guys all know that? No, you didn't. Okay, so one other little thing about blood flow to the heart is that this one was kind of interesting and took me a while too. Blood flow to the heart is really interesting because what happens is ventricular contraction, right, is going to push blood into your aorta, for instance, also the pulmonary trunk, but we're looking at systemic right now, okay? Push blood into your aorta, and when the ventricles contract, it also pushes blood into your coronary arteries, all of them, right? But simultaneously, and this is counterintuitive, what you're doing when your ventricles contract is you are also compressing the capillaries in the wall of the ventricles, right? Okay, good. So it's like squishing a sponge underwater. Does it actually take up the water when you squish it? No, it does when you relax your hand. So although it seems really counterintuitive to a lot of people, why is it that when your ventricles contract actually too fast, like with ventricular tachycardia or ventricular fibrillation, it will cause a heart attack? Well, it's because of this stuff that we've just said. What happens is you're pushing it into the arteries, but you're compressing the capillaries, so it's actually not going into the capillaries. It may seem counterintuitive that if your ventricles are contracting, 120 beats per minute or whatever, you can actually go into a heart attack. 200 beats per minute go into a heart attack because you're never actually delivering it to the muscle itself, the heart muscle itself. Is that cool? Okay. All right. So the last thing to cover in this set of notes is something that ends up being really important for physiology. It's really difficult to see anatomically unless you're actually looking at the histology. And this is what we call the conducting system of the heart and also the innervation of the heart. So let me introduce you to what we call the conducting system of the heart. Okay, so I think you've seen these in lab, but the only way you really see them is that somebody painted them on a model for you. Because anatomically, the gross anatomy of these structures, like the SA node and the AB node, they don't look dramatically different than the other tissues. Why the hell do you learn them? Because physiologically, they're pretty damn important. Okay, so what we have is most of the tissue that makes up cardiac muscle is contractile, right? It's muscular tissue, but not all of it. These are specialized muscle cells that are blobbed up, and all they do is cause contractions in their neighbors. So what they do is they spontaneously generate an electrical signal and then send it on to the neighbors that will then contract. Does that make sense? So they call these pacemaker cells, yes? Or sometimes conducting cells because they're conducting what's going on. Okay, so let's find them. This looks like it would be nervous tissue because it's represented similarly to other nervous tissue, but it's not. It's specialized cardiac muscle tissue that is actually responsible for controlling the heart. Okay, so let's meet the parts first. This guy right here is called the sinoatrial node, and the sinoatrial node is just inferior to the opening of the superior vena cava in the right atrium. That's where that one is. That is the boss of the whole thing in a healthy person. Okay, that is the one that controls what your heart rate is doing inherently before you even hook up the nervous system. That thing still works even if you yank all the nerves off of it. So for instance, in that situation, was the person wasn't alive any longer, right? The heart wasn't beating. They didn't keep the heart going. No. But if, for instance, you had a heart and you were doing a heart transplant and the person was maybe brain dead, so the heart was still beating, right? So what you can do is you can take the heart out, and as long as you flush it with ions, right, it will actually still beat. Yeah, there's like rich ions. So the thing I'm telling you is that unlike skeletal muscle, in which every cell has to be told what to do all the time, cardiac muscle actually generates its own contractions, and so it will still beat. Right? Not for very long because it's going to run out of nutrients and oxygen really quickly without being hooked up. Go ahead.
You have to give her a lot of heparin too. Does that have anything?
Yeah. Heparin is an anticoagulant. The receiver?
No, the donor.
Oh, yeah. So what they didn't want for her to be delivering a heart that's actually full of clots because then it's going to cause clotting in the other person. Yeah, cleans the blood out. Yeah. Okay. So this is the sinoatrial node. That's the boss. This is the underboss, right? The underboss takes its commands from the boss unless the boss is not around, and then it will make its own decisions. So this is called the AV node, the atrioventricular node. And the atrioventricular node is in the interatrial septum at the bottom. Okay. Now, what you are seeing from the atrioventricular node all the way down, this looks like nervous tissue, but it isn't. What it is, boss, underboss, those both control the contractile cells, but what this one does is sends the signal down a chain of minions. Right? This is called the AV bundle. It doesn't talk to the contractile cells yet, and this is going to be important for just a second. They used to call this the bundle of His because the guy named His found it. And then it splits into the left bundle branch that goes to the left ventricle and the right bundle branch that goes to the right ventricle. Good? Okay. Still is not talking to the contractile cells until it gets to these. Those are called the Purkinje fibers. Okay. So here's what happens, guys. Okay. The SA node sends a signal and tells the atria to contract. And the atria will contract in the order that they get the signal, which is top down. Yes? Isn't that how it's going to work? Because the SA node is at the top? Yes? About the time that the atrium is finished contracting, you will tell the underboss, the AV node, that it's now time for you to start going. But what the AV node does is it sends the signal down the middle, AV bundle, split into the left and right bundle branches, and then doesn't start talking to the contractile cells until you get to the Purkinje fibers. That will force two things to occur. First, forces a lag time between atrial contraction and ventricular contraction. Yes, can you see that? Right? What's happening during the lag time that's important? It's what?
Are they closing the
First, you are going to fill the ventricles, and then before you start closing anything, we're going to actually have the so basically what we're doing is we're squishing all the blood from the atrium to the ventricle. Does that make sense? Okay. And at rest, if your heart rate is around 75 beats per minute or so, there's about 0.2 of a second between atrial contraction and ventricular contraction. So it's filling, okay? So that's important, that pause, right? Because you don't want it to go atrial contraction, ventricular contraction, right? Then they're on top of one another. The other thing that's important is that if you don't start talking to the contractile cells until you get to the Purkinje fibers, that means that the ventricles are going to contract how? How are they going to contract? Bottom and sides up, which is exactly what you want them to do. Yes? Okay. So the ventricles are going to contract bottom and sides up. If you started talking to them here, they would contract in the middle before they contracted on the sides, and that's not what we want. So bottom and sides up. And then look at the first things to get the signal. It's your heart nipples. Your red rubber, there's blood coming over, right? So those get ready right before the walls start contracting, right? They get ready for the pressure that is going to increase. Does that make sense to you guys? So what's happening here is this whole arrangement forces contraction to occur both at the time you want and in the order that you want. Is that good? Okay, so now what we need to talk about is if the heart does this all on its own, what does the nervous system have the capacity to do for the heart? Okay, what? Yeah, it can influence the rate, but what it can't do, and this is important clinically, and it's going to be important for you guys taking care of me and other people, it can't restart the heart. So the starter of the heart is the sinoatrial node, right? That's the only thing that can dependably start a heart. If the car is not started, it doesn't matter whether you press the gas or the brakes, does it? No? So what the nervous system can do, and this is important, is the nervous system can only increase or decrease the rate that was already going with the sinoatrial node. So this picture looks super complicated. It's not as bad as you think, okay? What we're going to do is we're going to put together 3 different sets of notes to talk about how you control the heart with the autonomic nervous system, okay? So, first question for you. Which part of the brain is in control of heart rate? Medulla oblongata. Yes, that's where we're going to start. That's the medulla oblongata. Okay. What's happening with your heart right now is the SA node wants to start a contraction 100 beats per minute, but you don't need 100 beats per minute right now, do you? Right? So which branch of the autonomic nervous system is in control of your heart rate right now? Parasympathetic. Good. Okay. So how do you do parasympathetic slowdown, basically the brakes of the heart? What happens is you start, of course, in the medulla oblongata, right? And then you send out the stimulus through cranial nerve number 10. What's that one? Vagus nerve. And you send these green fibers to the SA node and the AV node, and what they do is put the brakes on. And the brakes are on your heart most of the time, okay? And what it does is it says, I don't need you to be 100 beats per minute. I need you to be 70 right now, okay? All right, so what's going to happen, though, if a tiger walks into the room is I need to take my foot off the brakes. It'll go back up to 100, but it's a freaking tiger. I need more than 100, yes? I'm going to need it to go higher than that. So then what I'm going to need to do is use medulla oblongata. This time, follow me, send the stimulus down to the thoracic region of the spinal cord. Yeah? Out to a ganglion, sympathetic chain ganglia, and then out to the SA node and the AV node, and that will bring it higher. Yes? So what the autonomic nervous system can do is to decide subconsciously. The medulla oblongata gets to be the decider, right? Decide subconsciously whether I need to increase or decrease the heart rate, right, at any given moment. Now, I always use tigers as an example, but FYI, you are also monitoring your own blood pressure right now. And if your blood pressure dropped, you would use that, not a tiger, to figure out that you actually needed to activate the sympathetic nervous system, right? So we always talk about it as fight or flight and feed or breed, but it's actually more complicated than that because you use it every time you walk to your car, right? That's you use the sympathetic nervous system every time you do that. Okay. The heart, by the way, is also innervated by visceral sensory nerve fibers. So can your heart hurt? Yes, it can. You can get angina and you can get a heart attack, and heart attacks hurt here, and then it's radiated that way because of the way the nerves work.
So those things,
Yeah.
defibrillators.
Yeah, I'm going to talk about this. Yeah, defibrillation.
So that must kickstart the SA node.
It's not exactly what it does, so let's figure out what it does. So we're going to talk about abnormalities of conduction, and then we'll talk about defibrillation, okay? So abnormalities of conduction. So there's a bunch of abnormalities of conduction. The only thing that's normal is when it goes atrial contraction, pause, ventricular contraction. Atrial contraction, pause, ventricular contraction, right? That's how your heart's supposed to work at different rates, but still that pattern, right? And there's a whole bunch of different abnormalities of conduction. You can have one side of your heart being wonky and the other side being fine. You can have just the atria being wonky and the ventricles are fine, or the opposite. So I'm just going to talk to you about 2 of them, okay? 2 abnormalities of conduction are the 2 different types of fibrillation, okay? And then we can talk about cardioverting and defibrillating. Okay, so with fibrillation, what's happening is one set of chambers is going just fine, but the other one is spazzing out. So atrial fibrillation, I'm not coordinated enough to do this, so imagine that I was, okay? Your ventricles are going just fine, right? They're just doing this, and your atria are spazzing out, and they're completely discoordinated with what's happening with your ventricles, okay? That's the one that I have, okay? Ventricular fibrillation is when your atria are going just fine, yes, and your ventricles are spazzing out. Good? Which one's going to kill you real fast if you don't intervene? Yeah, ventricular fibrillation is going to kill you really fast if you don't intervene, which is why, quite often, if you're in that situation, they will choose to cardiovert you or defibrillate. And there's actually chemicals you can use now, like if you were in an ambulance, first they would try to inject you with some chemicals, which could stop your heart from misbehaving. If that doesn't work, they can actually deliver an electrical shock. What the electrical shock actually does is clears out the electrical activity of your heart. It does not restart it. What it does is stops it from misbehaving. And then you just sit there and you wait for what? Yeah, you wait for the SA node to restart, okay? You were gonna die anyway. You really were. And the only thing that can actually restart your heart is the SA node. So what they have to do is they have to just clear it out and then hope it remembers how to behave. And if it doesn't, they're gonna clear it out again and hope it remembers how to behave. And they're gonna do it again and hope it remembers how to behave. So they're stopping the electrical activity and then waiting for the rhythmicity of your heart to restart itself. Go ahead, and then I'll answer the other one.
Okay, when would the AV node ever have to start action?
If the SA node goes bad on you, then the AV node, it's an underboss. It will continue to control ventricular contraction. It will just do it discoordinated from the SA node, okay? If you have the AV node discoordinated from the SA node, then what happens is your atria can contract, but your ventricles are contracting discoordinated from them. So what should happen is your SA node says, atria are contracting, now it's your turn, right? But even if they don't tell it when it's its turn, it will actually contract. It just won't be timed right? So it might contract when it's not always full, right? Okay, does that make sense? Okay, now with atrial fibrillation, which is the one that I have, it's not super uncommon. Atrial fibrillation, what happens is the ventricles are going just fine and they're still coordinated because, of course, the AV node keeps going, but the atria are spazzing out, okay? And that one is not immediately life-threatening, but it's not without its risks at all. So what happens with that one is if the atria are just spazzing out and they're really not contracting, they're just kind of feels really, really weird when it happens in your chest. What happens is you're not pushing as much blood into the ventricles because they're not wringing that 20% of blood. So your blood flow drops by about 20% instantaneously. You get super lightheaded and you can totally pass out associated with it, which is not particularly dangerous all the time unless you pass out on something pointy or you were driving at the time, right? So it can totally be dangerous in that way. So, but you got to sit down because, of course, you can't handle the extra pressure, right? Because your brain is not getting enough blood to begin with. So a lot of times you'll have to sit down or lay down. But the risk of atrial fibrillation, if you live through the bout, is that if you're in an atrial fibrillation for a decent amount of time, it's a decent amount of time. The longest I've ever been in atrial fibrillation was 48 hours, but I was in the hospital at the time. And so they were waiting for my SA node to kick back in. And you can see why with atrial fibrillation, they don't want to cardiovert unless it's been going on for a really long time, because of course you're still alive, right? So they told me they were going to have to cardiovert, and I was scared to death, and like I clicked it back in or something, clicked it back in. I don't know what the hell happened. But the big risk with atrial fibrillation, if you're in it for a while, is the blood is not getting moved out of your atria fast enough. What happens to blood when it just sort of sits around? Clots, exactly. So the problem is that after you've had a decent bout of atrial fibrillation, and a decent bout is anything more than about 10 minutes of atrial fibrillation, then you are at high risk of throwing a clot for about 2 weeks after. And if you throw it to your heart, it causes a heart attack. Throw it to your brain, it causes a stroke. Throw it to your lungs, it causes a pulmonary embolism. So whenever you're in a big bout, like I have had before, I have to shoot myself up with anticoagulants for weeks afterward, like heparin or something afterward. Or if you've got other complicating factors, like if you had hypertension and atrial fibrillation, right? Then you're at high risk and you're probably going to need an anticoagulant. Or if you were pregnant, like I had a child, but pregnancy increases your risk of clotting dramatically. All of the extra estrogen in your system and the higher blood pressure increases your risk of clotting. So the entire pregnancy, I had to shoot myself up with heparin in the leg the entire time, twice a day, to keep both of us alive during the pregnancy. So that's atrial fibrillation and ventricular fibrillation. Go ahead.
So when you see on TV somebody flatlines, that means no heartbeat, right?
It means no electrical activity of the heart. They don't actually measure the beat, but they measure the electrical activity, and what's happening electrically determines what's happening mechanically. Yeah.
So then, if there's still contraction going on and the defibrillator is just there to get it back on track, so how is there a flat line?
Oh no, it's not contracting at that point. No, you can use defibrillation to stop fibrillation, but you can also use it to hopefully remind the SA what its job is. And you're just delivering electrical shock, and sometimes it will take that input, that sensory input, to decide that it needs to do output. You can also manipulate the heart, right? Have you ever seen people do that, right? You can see it with CPR when they're doing it from the outside, but when they actually have the chest cavity open, they will actually squish it. And it's like you're going, do you remember? This is your job. Do you remember? This is your job. And sometimes it remembers that that's its job. It just takes the sensory input and then decides on the motor output based on that. So sometimes you're trying to shut it up, and sometimes you're trying to say, we're going to stop everything, and then just sit there and watch. I mean, you guys have seen ER and Grey's Anatomy and all kinds of stuff, and they're just clear, and then they wait. But the waiting is the humbling part, right? The waiting is I can't do a damn thing unless the SA node actually kicks back in. And it's really you really just can't do anything as a medical professional if the SA node doesn't work. I mean, you could implant a pacemaker if you could keep the person alive, but if they don't live through that acute situation, then a pacemaker is not even a possibility. Go ahead.
So if a person is brain dead, but their heart's still beating, their SA node is taking over, right?
Oh yeah. No,
brain
brain dead generally means that your cerebral cortex is gone. If their medulla oblongata was gone, they would probably have been dead.
Okay.
Yeah. So the autonomic nervous system can still control the activity of the heart. So if someone was brain dead and they were going to be an organ donor, then you can keep their tissues alive, right, until donation, right? It's crazy to talk about and weird and uncomfortable, but it is also what people do in those situations.
How
Go
far
ahead.
do they usually transplant hearts? You said they can keep them alive for a little bit?
What did you say?
Transplant hearts?
I didn't hear the first part of the question.
Oh, so if don't they usually sometimes if someone's in New York and someone's in this state, how do they transfer the hearts to them?
In a little cooler on a plane.
Do
Yeah.
they have to keep pumping?
No, as long as you keep the tissue alive. You can't keep it pumping unless it's going to be a donation that's in the same place. If, for instance, you were at the U, which is a research hospital, you would be far more likely to get a live donor donation than if you were, for instance, in Podunkville somewhere. So you're in a very, very fortunate place for biomedical research right here. Go ahead.
When you do a transfer, do they flush out all the blood out of the heart?
So they deliver anticoagulants. The donor has to be on heparin to flush out any potential clots, and then they try to clean out and run fluid through the heart before they actually do the donation. So you have to pull up.
A lot of saline.
Yeah, they flush the whole thing with a whole bunch of
How
saline.
long does that usually take before they can take it
I
out?
don't know. Haven't seen it done. Go ahead.
So does the sinoatrial node, it contracts the atrium, but it's the pressure from the blood on that valve that will actually open it, so it's not the SA?
It is not. That's a good question. So the SA node, the question she asked is, does the SA node actually open the valve? No. The SA node causes the contraction that generates the pressure that opens the valve. Yeah?
Okay, that makes sense.
Yeah? Okay. Those are really good questions. Those are better understanding questions than most anatomy students ask. A lot of times these questions don't come up until physiology, but if you've got a good anatomical understanding of the heart, it's going to make phys way easier. And the cardiovascular physiology is hard, so hard. It's it's one of those classes that I have to work myself up to go in to teach it because I know that like there's going to be daggers coming at me. I'm like, all right, just like put on my raincoat, bulletproof vest. Like you guys are mentally flipping me off. I'm mentally flipping you back off because like one of us is working harder than the other one here. Okay, so we are going to move to now vessels, okay? And you guys are, I don't know what I'm going to do with blood yet. We'll figure that out later. But I'm going to move to vessels because you guys are going to be doing vessels in lab this week. And I think you need more help with vessels than you do with the one blood slide that you had to learn, right? Okay, so you guys are going to be doing vessels in lab this week. And if you don't have the notes, it's all right. You can always take notes. Do you know that people do that? Like with their pen and their brain? I don't even know how they live that way. Do you? Live that way. Okay. So, like I told you guys before, if you are considering capillaries, and you should, you have in a 150-pound person about 60,000 miles of capillaries. There are so many. Look how many there are. And this is just the capillaries of the freaking head. Look at this. You're like a little fuzz buzz under there. You're so fuzzy underneath. Did you guys get to see Body Worlds or Bodies when it was here? If it ever comes, you should totally go see it again. And if you are a parent, take your kids. You might make a little scientist out of them right there. Of course, my son had to tell everybody, because he was 6 at the time, that you can tell the girl from the boy because that one's got breasts and that one's got a penis. I was like, thanks, Evan. I think they probably could have figured that out by themselves. But he had to let me know that. I just gave him a high five and then like stuck a sucker in his mouth. Okay, so as far as the structure of vessels go, first, I want to show you one more thing. This is not my father-in-law's, but this is the same kind of artificial valve that my father-in-law has. This is a replacement for a bad bicuspid valve. And this is a mechanical valve, and it opens and closes due to pressure, just like a door, a kitchen door, right? It opens and closes. That's what it looks like. It looks huge, but it's just the same size as it's blown up, just the same size as the bicuspid originally was. Okay, and that's not his. I wish I had a picture of his, but I didn't ask. Well, it increases the likelihood of clotting, and they have to be in the hospital for quite a while afterward because they're really afraid of them throwing a clot anytime they do any kind of intervention after that. Same thing with bypass surgery. You can understand why with bypass, not as much as this, but with bypass surgery, immediately after bypass surgery, because you just like knitted the vessels together, you're at increased risk of throwing clots. So they keep them on anticoagulants for a while, right? For a while before they actually let him go. Well, actually, they anticoagulants for a while, take them off anticoagulants, make sure they don't throw a clot, and then they get to be sent home. Same thing happened with me when I gave birth, is that I had to stay in the hospital for 9 days afterward, and I couldn't deliver vaginally because my heart couldn't take that pressure. I had to do a cesarean section, but since I have a clotting predisposition, they had to keep me on anticoagulants for 4 days and then off of anticoagulants for 4 days before they would actually send me home. But it was actually good because my son was in the NICU anyway, so we got to stay together. Oh. Yeah, he kept me 3 days longer than he needed to because he just wanted me to be there with my baby. He's like, I'm pretty sure I don't think you should go home. I was like, I shouldn't. You're right. So thank you, taxpayers, for paying my insurance. I think we were around. I think we were around $80,000 by the time we both left the hospital. But he's amazing. He's totally worth it. Yeah. You guys would love him. Okay.
So anticoagulants, that's the same thing as blood thinners, right?
I hate the word blood thinners.
Okay.
They are anticoagulants because they don't actually thin your blood. They just make it less likely that it would clot. Yeah, they don't actually make it thin. Okay, so I want to look at this counterintuitive thing that a lot of people wouldn't immediately grasp, and that is that when you look at an artery versus a vein, it is counterintuitive. People tend to think that arteries are bigger than veins because they stand up better, right? And if you start looking at a cadaver, right, you're like, oh, the artery is like standing up and the vein is collapsing. And it makes you think that arteries are bigger than veins, but they're not. Arteries are simply thicker walled than veins, yes? okay? They have a much thicker wall. So here's an artery and a vein of about the same relative diameter, right? But notice the thickness of the wall in the artery and the thickness of the wall in the vein. So it helped me to verbalize why arteries are both thicker in the wall and why they need more elasticity in the wall. So why thicker? Go ahead. Yeah, that is why. It's got way more smooth muscle. Why does it need to be thicker?
Because there's a lot of pressure.
A lot of pressure, right? So if you're thin-walled and weak-walled, right, and you generate a whole bunch of pressure and push into a tube, then you can bust the damn tube. It's called an aneurysm, right? Okay, so you need to be thicker. And most of this musculature, by the way, most of it is just for structural stability in the wall, okay? In addition, they also need to be more elastic, because which of those vessels receives not only higher pressure, but squirty pressure? Yeah? Arteries receive squirty pressure, right? It goes squish, and then the artery balloons out just a little bit, and it has to snap back, right? Go ahead.
I was going to ask, so can arteries lose some of the wall, like the muscle? Or is that like a genetic thing? You're just born with thinner arteries?
Yeah, you can be born with thinner arteries. I have a weakness in the walls of my arteries. This is part of the reason that I have that problem. Usually it's not everywhere in your arteries. It's like you'll just have one weak spot, but you would never discover unless you got hypertension or super duper stressed out. So yes, you can have a genetic predisposition to a weakness in the walls of your arteries. Okay, so it receives squirty pressure. So not only does it receive higher pressure, but the pressure goes up immediately after ventricular contraction, right? And then drops, right? And it goes up again and then drops. So imagine that this was maybe your aorta, squirt, squirt, squirt. So you're gonna have a structurally stable wall with elasticity in the wall. And this is your inferior vena cava, okay? The vessels, the veins, do not receive blood in squirts. They receive it in trickles, yes? On the backside of a capillary bed. So they do not have squirty blood, and it's way lower pressure. Does that make sense? So structurally, the wall can be thinner, right? And then, anybody have any idea why I would want the lumen of my artery to, compared to a vein of the same size, I want the lumen to actually be a little smaller? Have any idea? Yes, exactly, right? It creates more pressure. I think of it this way. If you actually make the lumen a little smaller, then the blood flow is going to be a little faster, right? Okay, because arteries are on their way to work, and they gotta hurry. Aren't you always almost 5 minutes late? Almost always, right? Almost, right? Here, you're on your way home. You're gonna stop at Target for an hour and a half, because when you get home, somebody's gonna make you cook something, and you know it, right? Okay, you know it, okay? You're like, I didn't even need anything at Target, and now I do not have $200 that I had when I walked in there, right? Okay, so they are going to be a larger lumen. Okay, so let's look at basically what you have in these. What you have in any vessel that is not a capillary, capillaries are a little different, is you have 3 layers. They call them tunics or tunica. The tunica intima, which is the one that's touching the blood. It's the internal layer, internal tunic or coat. The tunica media, which is the middle one, that's where the muscle is. Yes, that is primarily smooth muscle. And then the tunica externa, which is the connective tissue that sort of weaves the vessel into the other tissues. By the way, when you look at the cadavers this week, realize that you wouldn't be able to just open up an arm and see a brachial artery. The reason it's sitting out right there is because we pulled it out for you. It was all stuck to the muscles, right? And woven in, because on the outside of vessels is connective tissue that weaves them into whatever is around them, right? So the reason that all of these vessels are just hanging out for you to see them is because we went down and separated them from the other things. So they're all woven into. Okay, so the tunica intima, the inner layer, comes in contact with the blood. What kind of tissue do you think comes in contact with the blood? Yeah, it's simple squamous epithelium. When it's inside the cardiovascular system, they call it endothelium, but it is simple squamous epithelium. It needs to be nice and slippery so that we can avoid clotting on accident, right? Deep to that, we're going to have connective tissue, because you always have connective tissue under an epithelial tissue. That shouldn't surprise anybody, okay? But then arteries have one extra layer. They have an internal elastic membrane that a vein doesn't, okay? because they have an extra layer of elasticity because, again, squirty blood, right? Okay, so they've got that layer, and they're going to have one more as we move out. Then we're going to move to muscle, the tunica media layer. This is smooth muscle arranged circularly. Okay, I want to think about this for just a second. The smooth muscle, here's the tube, and it's arranged circularly like this, right? Okay. First is providing structural stability, right? Sometimes it doesn't ever constrict, it just provides structural stability. In some places, for instance, you never want the smooth muscle of a vessel to constrict, like the aorta. Do you ever want your aorta to constrict? No, that doesn't happen in a healthy person. We want it to be structurally stable, but we never actually want it to narrow, right? In other places, we want structural stability and the ability to increase and decrease the lumen diameter. So let's say I was in an artery that was leading, arterial that was leading to a capillary bed. I'd get the circular smooth muscle. If I stimulate the smooth muscle, what does it do to the lumen? The diameter of the lumen. It decreases the diameter of the lumen, right? If I relax it, it increases the diameter of the lumen. So that's how you cause vasoconstriction and vasodilation. FYI, that's controlled by the sympathetic nervous system as well. So this is the tunica media. Always for structural stability, can in some places allow for vasoconstriction and vasodilation. Then superficial to the tunica media is this layer right here, only in an artery, another layer of elastic, okay? This is the external elastic lamina or layer, okay? Don't have one over here. And then superficial to that is the connective tissue that weaves it into other places called the tunica externa. Good? Go ahead.
So the tunica intima, like, where is it in comparison to the endothelium?
Oh, it's the tunica intima is made up of endothelium. Yeah? Okay, so the endothelium is just like the tissue category, right? The tunica intima means the inner coat or the inner layer, right? Does that make sense? Okay, so it's made up primarily of endothelium. A lot of people include this layer in it as well, the layer that's just deep to it. Okay, so those are the three layers. Okay, so now what I want to do is compare arteries to other kinds of vessels. Okay, do you think that you could immediately now, with what we've said, tell in cross-section artery from a vein? Yeah, you could, right? Because you can tell with the difference in the size of the wall, right? Okay, veins tend to be much, much wider in their lumen and thinner walled, and arteries are skinny. What do you think about this little guy right here? Any idea what that might be? No. No, it's a vessel. It's an arterial. It's a little thin, it's a little tiny artery, but you can tell because the wall is still relatively thick compared to the size of the lumen. So that's an arterial. Okay, so what we're going to do now is we're going to meet arteries and talk about how they actually supply things. Arteries are vessels that carry blood, of course, from the heart to a capillary bed. Does it make sense to you that quite often they call arteries efferent vessels? Efferent vessels? Yeah? Okay. And you guys remind me, because you should know this. Arteries carry oxygenated blood in what circuit? Systemic. And deoxygenated blood in the pulmonary circuit. Good. The vessel wall is thicker and stronger than a vein because the pressure is always greater. And as a result of the structure of the vessel walls of an artery, they have contractility, which doesn't necessarily mean that they're going to narrow. It means that they are stable, and some of them do narrow. And they also have elasticity because of all that elastic in the wall. That elastic, by the way, is compromised as well when people, for instance, start to do this. This is arteriosclerosis or atherosclerosis. They a lot of times refer to as hardening of the arteries. Okay, so we can look at the narrowing and we can say, okay, the narrowing is definitely a problem because it's going to compromise blood flow. But what I want you to know is that later on, as this has been sitting there for a little while, it also makes the wall of the artery sort of calcified and hard. So it also hardens the artery and compromises the elasticity of the artery. Does that make sense? And the elasticity is important because, think about the aorta for just a second. That's not the aorta, but just think about the aorta as an example. So when the blood pushes from the ventricle into the aorta, right? Okay, the aorta balloons out and then snaps back. When it snaps back, the semilunar valve is closed. So the snapback actually acts as a little ancillary pump to help move blood forward. So what happens when your arteries not only get clogged up but also get hardened in the walls is that it compromises the sort of snapback, and you don't have as good a blood flow through your arteries. Does that make sense? So they call it hardening of the arteries, but it's both narrowing and hardening of the arteries is the things that go on. This starts out as just like a little fatty blob on the walls, and then later on it actually crystallizes in the walls. It becomes really hard and crystalline. It's pretty damn fascinating because most of our cadavers, of course, are elderly. All of our cadavers are elderly. And some of them died of complications related to cardiovascular abnormalities and heart disease and congestive heart failure. We had one last year or 2 years ago that when we opened her up and we're starting to look at her vessels, I just took my fingers and I ran it down her femoral artery, and it was just crunchy. The entire thing was crunchy all the way down. And then I opened it up and she had like crystals forming in the walls, just like from arteriosclerosis and atherosclerosis. So it was pretty damn interesting. And no, I did not eat a burger that day, I promise you. Okay. Okay. So one interesting thing about arteries is that we have evolved to have redundant circulation with capillary beds. I'll draw this again for you guys. Okay, so what is often the case is, okay, I've got any organ, doesn't matter which one, and I've got a capillary bed to that organ. And you could, of course, just have one big artery delivering blood to a capillary bed. But this would be problematic, of course, if that artery ever got blocked or damaged or anything. So what tends to happen is that quite often, especially in very precious places in the body, what we have is redundant circulation with two arteries going in. But then in addition, this is called collateral circulation. In addition, I've also got a detour in case one of them gets blocked. So let's say I have a blockage right here. What we often have is a location called anastomosis, in which I have an alternate route of circulation. Can you see that although it would originally look like if one of these was blocked, you would cut blood flow by half? This doesn't cut it by half, right? So you'll still get the vast majority of the blood flow. Will it cut it down a little bit? Yeah, probably, but not by half, right? So this is called collateral circulation, and that is an anastomosis. Plural is anastomoses. That's the alternate route of circulation. And most parts of the body have that. Of course, one super duper important part to have alternate routes of circulation in case a blockage occurs is the brain, right? So that we talked about this before, so let's just reinforce this, right? So this is the arterial blood flow to the brain, and this is a classic example of like redundant collateral circulation, right? And anastomoses forming so that you have an alternate route of circulation. And this whole subject right here is the reason that I'm alive, because again, we talked about this before. We've got 4 vessels going to your brain, right? In a minute, you guys are going to learn these, but I'll go ahead and show them to you now. These are the 2 vertebral arteries. These are the 2 internal carotid arteries. Yes? Okay. But notice how this is a circle, and you have a bunch of alternate routes of circulation. So what happened with me is this one busted a freaking hole in it, right? If I did not have collateral circulation, what that would have done is probably kill off blood flow to this portion of my brain, right? This portion of my brain. And so my brainstem and my occipital lobe would have died. Didn't happen. Why? Because when this one died, I had this alternate route of circulation that could go all the way around to this side, right? Because of that circle that you have in there. Does that make sense? Okay, so that's collateral circulation. You guys will learn not all of these vessels. You'll learn 1, 2, 3, just 5. Okay, I want to put them all in there, but everybody keeps stopping me from adding more stuff. So, all right. So, as far as the kinds of arteries go, there are actually 3 different categories of arteries as you move away from your heart, and this is relatively easy. So you guys tell me, as we are when we're close to the heart, is elasticity or contractility more important? elasticity, right? You don't need to do a whole lot of vasoconstriction and vasodilation. As you get further away from the heart, do you see that elasticity is going to become less important? Yeah? But contractility is going to become more important because what arterials do is they control blood flow to capillary beds, right? And they do that by vasoconstriction and vasodilation, right? So here's what happens. As you move away from the heart, elasticity gets less important and contractility gets more important. So the vessels that are right close to the heart, like the aorta, for example, is called an elastic artery because although it has a bunch of muscle in the wall, it's not super wiggly, right? It's primarily for structural stability. Elasticity is super important. As you move further away from the heart, like in the brachial artery, the radial artery, the ulnar artery, then you're what's called a muscular artery. It's still got elasticity, but compared to the size of the lumen, there's a whole bunch of muscle in the wall compared to the size of the lumen. And then you're going to move to an arterial. Most of the arteries that you're going to learn by name are muscular arteries. You don't learn any of those by name because they're so variable between people. They're also hardly visible with the naked eye. So those are arterials. Arterials are not super stretchy, but they are super wiggly. They control blood flow to capillary beds. Good? Okay. And then once we get into a capillary bed, what we will see is that capillaries are a little different than our other vessels. The capillaries, these are all microscopic. Can't see them with the naked eye. Interestingly, because we can't see capillaries with the naked eye, people had some pretty interesting assumptions about how blood flow worked before we had microscopy. Because if you think about it, what it looks like, right, is that blood is just sort of going to an area, right? And then blood is just coming back through an area, but you don't ever see it going through, right? So what they thought for a long time was that blood just kind of waved in and slushed into the tissue. And then it just slushed back, right? You're like, no idea what's going on down there because you couldn't see microscopy. So they didn't think that it was all connected by tubes. They thought it just slushes in there and then somehow it makes it back into the other tube by magic. So when you don't know science, everything looks like magic. Okay, so when you look at a capillary, capillaries are really, really simple in structure because they need to be. They don't have any smooth muscle in their wall. They don't have any connective tissue in their wall because their entire job is to be thin enough and branched enough that you are going to do massive diffusion of oxygen, diffusion of carbon dioxide, diffusion of nutrients, diffusion of waste products, right? So they're really, really branched and super duper thin, and they are only composed of a single layer of simple squamous epithelium, endothelium, with a basement membrane underneath, nothing else, right? So they don't have all these tunics that we've been talking about. It's just as simple as you can get it. So capillaries are microscopic, and they're the only blood vessels whose walls permit exchange between the blood and the tissue fluids. And their primary function is to allow exchange of nutrients and waste. But they do one other function, and let's see if we can make this make sense. Okay, so tell me which end of this capillary bed do you think is going to be higher pressure? The arterial end or the venous end? Okay, arterial end. Do you guys remember from 1610 and every other class that you took related to this that filtration is pressure driven? Do you remember that filtration is pressure driven? What filtration does is it pushes water and anything teeny tiny that will fit through holes, right, from high pressure to low pressure. So what's going to happen at the systemic end of it, or the arterial end of a capillary bed, is that you are going to lose fluid and solutes into the interstitial fluid from the blood, right? Okay. What that's going to do is, of course, drop pressure as you move through here, right? If you lose fluid, you're going to drop pressure. Does that make sense to you guys? Okay. So you're going to push fluid and small solutes out, okay? And it happens at every single capillary bed that you have. If you didn't pull it back in, you would end up looking like the Stay Puft Marshmallow Man with all of that fluid leaking into your interstitial fluid. So there's a mechanism of bringing the vast majority of it back in. So you push it out by filtration, but then since you lost mostly fluid and very few solids, what happens is now you have a really concentrated solution inside the bloodstream that's going to pull it back up by osmosis. And I know everybody hates osmosis because even though you've had it 27 times, I still have to teach it in physiology again. Again. I'm like, why the hell do I have to draw that red blood cell on the board for the 72nd time in your education? But I'm gonna, right? Okay, so you pull it back in. So what that ends up doing is you get turnover of interstitial fluid. That is where your interstitial fluid comes from. It gets pushed out of the capillary, sucked back up by osmosis. Pushed out, sucked up, pushed out, sucked up. So you've got fresh interstitial fluid being formed all the time as you go through your capillary beds. Good? Okay, still, you don't pull all of it back in, so you always are going to be lower pressure over here for a couple of reasons. First, of course, you're further away from the pump on the other side of the capillary bed. Second, you have less fluid, right? Okay, so, and then there's another reason as well, because remember, the tube is bigger, right? Once you get back into the vein, so venous pressure is always way lower than arterial pressure. Wider lumen, yeah, less fluid, further away from the pump. Good? Okay. So we are going to stop there today because that's